move pretty quickly into the next panel, and I'll call the next panelists up here just to kind of give people a sense of kind of preview where the rest of the day.
Should we go to it now, just to make sure we
the
cover
immediate
it?
future. We'll do this panel. We will then, around 11:45, take a 15-minute break, which will allow people to come in here and set up for the lunch. Anybody, I think everybody has a food, anybody who has a particular food preference has a food preference card, so leave that near your seat so the wait staff know what meals to put where. So at the end of this, we'll all quickly go out so that they can make up the table for lunch, and then we'll come back here for the lunch panel. Hello? Hello? Okay. Am I on? All right. I think I am now. So we'll start our next panel. And I do want to just one of the questions around the bills that are going through, keep coming up, and there are kind of three processes going through. And just want, because I know there are a lot of people who are very involved in advocacy here who might be very interested in ways that they can weigh in. So the president put forward his budget, which introduces the food aid, overall food aid reform that Senator Isakson spoke here. So that's the appropriation process. And often in budget, when the president puts forward a budget, it will include things that are new areas that the administration moves towards. So there's the appropriation process that looks at this change in monetization practice, flexibility in food purchasing, as well as vouchers and cash. And so really kind of a broad look at food aid reform. There's the bill going through the House that was mentioned, the Royce-Bass bill, which is really looking at kind of more of a authorizing, putting into a bill that's long-term that will look at reforming emergency food aid. And then there's the farm bill that's being marked up through Senate, which will really look at how what is currently in the Department of Agriculture could actually be reformed to be parallel to what the president's budget has called for. So there's these three different tracks that are going through, and there are people here who can go into a lot more detail about that, but I just thought it was important for people to realize this is kind of three different budgetary track as well as authorizing legislation on these. So now to our next panel. I'm really pleased to have this panel that really focuses on the issue of children in all that we're talking about. And let me first introduce our panelists. We have, to my far left is Helene, who is the head of the Food Livelihood Justice Team within CARE. And he leads this team whose mandate is to lead CARE's commitment to ending global hunger and undernutrition by promoting a just global food system. This team within CARE harnesses knowledge from both within and outside of CARE to influence thought leadership around these areas. Fahim comes to us from a long career in CARE, working most recently in Bangladesh, where he was very instrumental in leading a program that I know he'll talk about, Shoharda, that had a huge impact on malnutrition in Bangladesh. Usha Ramakrishnan is next, is Associate Professor of Global Health at the Rollins School of Public Health at Emory. Her major area of research is maternal and child nutrition. She's had specific interests, including the functional consequences of micronutrient malnutrition, which Dr. Frieden talks so much about, during pregnancy and young children. And last night I also learned what an incredibly powerful voice she is around the issues of women's empowerment. We're pleased to have Usha with us. And then finally, Dr. Rafael Flores-Ayala, who is the team leader for International Micronutrient Malnutrition Prevention and Control, or IMPACT, program with the Centers for Disease Control and Prevention. He's got extensive experience in design, monitoring, and evaluation of large-scale nutrition programs, as well as developing international randomized clinical trials looking at nutrition, human capital formation, and growth and impact. So, we have with us people representing academia, the government, the civil society, NGO sector, and wonderful to have everybody today with you. What I wanted to do is really first frame these issues a little bit and then throw out some questions that people can respond to. We've talked a lot about this whole issue of why the importance, the key role that undernutrition and hunger plays, and our core goals to eliminate this. But in this panel, we really want to talk about how this hits children. And malnutrition really does hit children hardest. 1 out of 6 infants are born with low birth weight in developing countries. About 20 million children worldwide were estimated to suffer from severe acute malnutrition. And we know what that means in terms of leaving them vulnerable to infections, poor growth, poor developmental outcomes, etc. In 2010, it was estimated that 170 million children below age 5 are either stunted, and 104 million were underweight, so huge for children. We know that this contributes to about 1/3 of all global child deaths. And as I mentioned earlier, every 5 seconds a child dies from hunger-related disease. So the impact on children is undisputable. What we want to really examine in this panel is why. What are the issues, and how can this kind of multi-sector, multi-discipline approach really have an impact on that? So let me just start out first, and from your different perspectives, just why is this issue of undernutrition such an issue for children, particularly around the world? What are the factors that contribute to it, and how do you see it from your perspective? And each of you just give some thoughts on that. Now let's start with you.
Well, thanks for the invitation to Helene and Wayne and Steve to participate in the panel. And happy to be here with different sectors, not just the academia or the government, but the private sector and the NGOs. Undernutrition is multi-causal, as we know. First thing is that kids have inadequate diet and are exposed to disease. And Dr. Frieden spoke about the interaction between nutrition and infection. That's the first level. But why is that? Because it's household insecurity, because there are no care services, maternal and child care services, because there is an unhealthy environment, and also because the health service don't provide what is needed to overcome those 2 main immediate causes. But below that, there are the root causes, are the financial, the human capital, the social investments at the whole society. So undernutrition is multi-causal, and the approach has to be multi-causal, and then it has to be in the direction of which factors are going and what is the role of each of the sectors in doing that. Why are the children the most affected, and which group in the children? And clearly are children under 2. They are the most vulnerable group. And that's where you have heard about the 1,000 days, because it starts during pregnancy. So if a child doesn't grow as expected during the pregnancy, it will start stunting. And so it will become, once 2 years, recovery of linear growth pretty much is minimal.
Mm-hmm. Usha, from your perspective, what are some of the issues around children's specific vulnerability, and who gets affected the most?
I'd like to build on what Rafa just said, and the fundamentals is in the biology. As a human race, we've evolved, and children in the first 2 years of life, particularly the first year of life, are completely dependent on someone else to feed them, to clean them, to take care of them. And so when you're living in environments when those functions cannot be carried out, it immediately shows in the growth of the child. It's suboptimal. So in many ways, stunting or markers of undernutrition really reflect poverty, inequity, poor access to care. Specifically, what I'd like to focus is on the role of the caregiver. It's almost 20 years now, but the UNICEF conceptual framework that many of us teach in our classes that evolved from early work in the 70s, so this is not something new in Tanzania, looked at sort of the causality of stunting and identified, if you think immediately, it is repeated infections combined with poor feeding practices, inadequate food. And that can happen in the absence of food insecurity too. There could be food in the house. Many of you here know this failure to thrive. If the mother is unable to feed the child, there are factors that take her away from the child. Those would also come in the way. And then as you move sort of further down, you of course get into the availability of food services, support for women, women's empowerment, and we can backtrack. So it's really a complex sort of etiology, yet at the same time we can't wave our hands up and say we can't do anything about it. There are people who can work right at the level of the mother, empowering her to be able to take a better job of feeding her child. I think the other issue is taking care of young children. As a mother myself, is time consuming. So really keeping in mind it comes back to poverty, what are the constraints? Do women have the services that are available? If fed soon after they fall ill, that will prevent some of the stunting. So I think there's a lot of knowledge, but what I'd like to emphasize is there's really a lot of work in the area of behavior change. I know CARE is working. Infant and young child feeding practices are extremely important. And finally, something which is really important, it depends on the context of speaking, but the importance of maternal nutrition. Women are undernourished. If they're not getting enough food to eat, that affects the growth of the child, starting right at the time of conception, and in many ways programs that child to be undernourished through the next generation. So we're dealing with intergenerational effects of small women having children too early, so they are physiologically immature, but they're also in settings with poor food intake, poor care for themselves. So I think those are some key issues that need to be tackled, and they're tough issues.
Yeah, we'll come back to I think, one that you kind of implied, we talk about food as if, it's a monolith and not about what are the right foods, and, kind of looking at appropriate and proper nutrition and weaning practices and some of these other things that are very complicated. We can come back into that. Helene, you may want to touch on that, but also I think, some of the experience that you had in Bangladesh, and particularly around Shoharda, would be interesting to touch on around this issue of why children.
Well, thanks, Helene. Just to lead into the discussion, I categorize into two different things. One is poverty. So basically, just because of the status of households and people, they're deprived of, first off, just having an adequate food basket. Some of the places that we actually work in, they're extremely marginalized. They're extremely remote. Even getting to markets is a big, difficult issue. Once they get to the markets, they don't have enough money to buy food. That's another big issue. And then, the issue of, just the disenfranchisement in terms of the government, not necessarily seeing them as equal kind of citizens of the country. That's another big issue. But then stepping into, and I think it's just been covered, is the behavioral change aspect as well. And quite honestly, that transcends, poor countries and rich countries. Quite honestly, we see it in the States, we see it in the UK, Europe. Just poor, nutritional kind of diets. Poor decisions on what's actually, coming onto the table, and that actually brings in a more of a root problem. In the sense that traditionally, when we look at development programs, they're looking at food systems, they're looking at agricultural systems, and that's all good. About the behavioral change, which is the nutrition side of things. And that's the step where we need to be actually now transcending to get into that component. I'm really pleased today. That we actually have, academia, we have, civil society, we have government, private sector. And again, I think it's just been echoed again and again throughout the day that it really is a common partnership. This is not going to be done by any one institution. It's going to be, truly a combination of efforts. I can go into Shahada now, it's going, or I can talk about it.
We can come back to it later, because the next thing I want to kind of ask is about some of the practical experiences that all of you have had in this area of maternal and child nutrition. And I'm glad you brought up the maternal, because I think we often forget that one of the real kind of genesis of child malnutrition is when women aren't fed, and we know there's a whole range of issues around that. But all of you have been involved in practical, on-the-ground experiences, some that have worked well, some that have not worked as well in this area. So I'd like to just hear from all of you, give an example of programs that you've been involved in, what worked well, what didn't work well, where were the challenges, what could we do better? And then, this issue of how you actually measure the impact, because we all talk about impact. We all know how difficult it is to measure, but your experience with the ability to actually demonstrate what works and what doesn't in this area. So, kind of your practical experience and what we can learn from it.
Okay, in terms of effective solutions working at the national scale, I reflect on the areas that we work in our program. Definitely vitamin A supplementation for children under 5 years of age. That at national scale, it is in many countries and it is working. How you measure that? Well, sometimes to measure impact, you don't need to go to a randomized trial. So you can step back and say what is really needed. In the case of vitamin A supplementation, it's coverage. That's the easiest measure. That's how it's been done all over the world. Second intervention that
and coverage, because we already know that it works.
Exactly.
So in that case, we didn't need to prove it. We've already proven it. There's been lots of studies, and now for vitamin A, it's really, can you get it out there?
Exactly.
Okay.
Exactly. The second is universal salt iodization, because that goes fortification to the family diet. We heard in the previous panel about the importance of iodine in the diet, not just of the kids, of everybody, and in particular of mothers. So that is working. It is pretty much all over the world. It's a national scale. That doesn't mean that we have to forget about monitoring. And again, coverage. You don't need to prove again that it's going to be working. And the third I pick is wheat and corn flour fortification. It's very clear that wheat flour fortification has a tremendous impact on birth defects. From the randomized trials to efficacy, from the efficacy trials to the effectiveness trials, when you go into iron deficiency anemia, it's not so clear. So maybe there we still need some large effectiveness measurements in some fortification programs in terms of iron deficiency anemia, for example, for women in reproductive age. The next one I pick is a new one. Home fortification with micronutrient powers in children 6 to 23 months. Why? Because if you're going to improve the diet of the target group, that is really the crucial group, how you're going to do it in the short term. The only way is to fortify the food that is at home with the essential micronutrients and nutrients that they are lacking. And still, there are enough studies to show that they have impact on anemia and iron deficiency anemia, but many countries, when they are going, right now, 2 years ago, 20 countries that they were having programs, and there were about 95 programs all over the world. Now this is growing very rapidly and quickly. In terms of measuring impact, still some of the countries are requesting that they wanted to see the impact in their own country. Lately, the last one, Uganda, for example. And finally, I pick an intervention that we don't work at CDC, but has proven that it works because it goes into the root factors, it goes into the medium factors, and it goes into the immediate causes. And those are conditional cash transfer programs. You heard about Brazil, but Mexico was the first one, and Peru is the last one. In Latin America, there are 20 running on in Latin America, and there are like 4 running in Africa, starting 2 in Asia. Those comprehensive programs go into the roots and include nutrition components. Those are the ones that, in my opinion, are working.
Great, and you talked about interventions that we now have a lot of evidence to demonstrate their impact if used appropriately and scaled up. And maybe we can talk about or come back later to where are the impediments to actually making it happen, because I think that's the challenge. These are the things that we know can make a difference, but we know that they're not getting out there. And I think we do want to explore, so why not? Why is this not everywhere? Why are we not doing it? What are some of the impediments? Usha, you want to say from your experience some of the things that you know have made a difference?
Sure. As the academic who didn't plan to get into academia, my early experience going quite a while back was working in India as part of the Integrated Child Development Services program that CARE. In those days, there used to be food that came through PL 480. And over the years, my focus has moved towards maternal nutrition because one of the lessons learned very early was pregnant women, nursing women, women with young children do not access the services. So you have a program, the Indian government recognized that it was important to provide food supplements in areas where there's food insecurity, et cetera, but they do not access it. And so this is a fundamental issue that the most vulnerable, that first 1,000 days, they're the ones who aren't able to get, whether even if you have a primary health care center or a frontline worker, they're hidden. And for the various reasons, as I said, there's social issues, the mother is busy taking care of the child, and these programs have targeted children up to 6 years of age, and the 3-year-old would go and get his or her food, and now we know that it's too late. So I want to sort of put that in the background. In terms of sort of the glass full, glass empty, my understanding of programs and having taught this is there's a lot of promise in a very broad field that's investing in women's education, girls' education. I think we have a lot of evidence that shows in places where this investment has been made, the programs that you put in place, whether it is fortification, whether it is providing food supplementation, whether it's water and sanitation, the returns to these programs are dramatically higher. And most recently, Dr. Ray Martorell, who couldn't be here today, who's worked a lot in this area, we, with the support of the Gates Foundation, completed a task of looking at the evidence base for the importance of maternal nutrition. So these are, I can comment on some of the interventions of why we are now saying even in those first 1,000 days, the first 500 days are really, really important. It's not discounting the second year, but you start earlier. And in the evidence base, just to add to Rafa's list of things that we know to work, we know if women took iron and folic acid supplements, this is the prenatal vitamins, during pregnancy, you could improve birth outcomes, you can reduce the burden of preterm and low birth weight. More recently, and some of this has been my research, we find that providing multiple micronutrients, and this is basically a multivitamin mineral supplement that most people in developed countries and in developing countries, if they can afford it, would take during pregnancy but are not available to the ones who need it the most, has an even additional benefit of reducing the growth retardation that happens in utero. So, this part of the baby is born with a handicap. So that's an area. The other area of an intervention is calcium supplementation, which has been ignored for a very long time, and we have very strong evidence showing that, so someone talked about livestock and the importance of calcium supplementation during pregnancies to reduce preterm delivery. And a baby who's born preterm is even worse off because he or she is not only small because he arrived earlier, they're vulnerable to infections. And if you're in a poor environment, 20 years ago, most of these children would have died, even in settings like here. It's with advanced care that we're able to keep the children alive, but it's very expensive. So we can have cost-effective ways of reducing the burden. In a specific example with the Gates Foundation work, we also looked at programs. So, we were looking at the evidence, but we said, what has worked on the ground? We looked at 3 countries, Ethiopia, Nigeria, and India, and I'm most familiar with India. That's where I'm from originally, and we worked. And what I wanted to share is we used a different approach when we said about programs working. Again, what can we learn from the successes? And therefore, we picked a southern state where I'm from, and that partly might explain why I'm sitting over here, Tamil Nadu, to the northern states. So India, again, is a subcontinent. As someone said, Africa is not a country. In many ways, India, I can say that, is a very heterogeneous. The states are like countries in many parts of Latin America where I've worked. And the burden of undernutrition is very high in the northern states, in UP, Bihar, where the Gates Foundation is invested. And we were looking at what's worked in the south, why have the advances not been in the north? And once again, what came out very strikingly is this investment in women, a strong public health infrastructure. We used a combination of qualitative methods, but also looking at actual programs. And clearly a message that came out is the culture of investing in women, in empowering women, that there have been generational changes in women, whether it's seeking antenatal care. So you can have a clinic, but does the woman go to seek that care? What does it take to support that woman to seek care? You get back into the cultural issues. And I'm not an expert in Africa, but I know disempowered people have the same issues worldwide. And so those are some lessons which I'd like to share.
That's great. And Fahim, maybe following on, I think you've had some similar sort of experiences in your work.
Absolutely, Helene. So I'm not going to go into the science of, under-2 nutrition and everything else. I think that's been said, quite extensively. What I actually like to bring is, and we've been hearing this about evidence-based, kind of programming and so on. And I'm going to give you an example of the Shaharda program, which is funded by USAID and the government of Bangladesh. Essentially, before the program actually came to being, it's in 2004. We're traditionally faced with the traditional way of actually doing programming. So you actually have, a pot of money is either dealing with income generation, or a pot of money with food security, or a pot of money with women empowerment, and you're doing, individual portions, but of a much, wider thing that you're trying to actually have an impact on. And really, then you start getting to the challenges of trying to actually find, again, programs on the ground where you can partner. Of course, we actively promote that. But again, there's deficiencies in certain areas where, maybe you don't actually have all those different things, all those different elements actually working. Well, Shaharda was one of those programs where we actually had a real opportunity to actually try and do a kind of an integrated approach. It was a multitude of different things that we tried. And what was really good right from the onset was that 10% of that funding was given by the government of Bangladesh, which immediately brought them on as an active partner in the process. Now Shaharda was actively looking at an individual level, at a household level, at a community level, at a local, regional, and national level as well. So it was actually building all those different things into it. We were looking at basically, developing the capacities of individuals and households to be able to generate more income. Looking at, essentially the markets that were prevalent in that area and trying to make them more accessible. We were looking at health, hygiene, nutrition, played a major component in that as well. Women empowerment was another big factor in that. Institutional strengthening and development came into that as well. And then you had also, the disaster risk reduction and management. So if you look at the traditional, kind of literature of food and nutrition security, we're pretty much dealing with all 4 domains: the availability, access, utilization, and stability. When we actually began the program, it was a challenge because there were so many things that we actually had to deal with. But I think, as we were going through the process, some proxy indicators of going on the right track. When we began the program, we had 9 ministries sitting on our steering committee. By the end of the program, we had 13 ministries, 4 government departments, and we actually had to turn away people from the program because there was so much interest actually coming in. And this was fundamental when you look at the sustainability of the program, because the intention was that care would be there for a finite period and they would actually move on. By the end of the program, essentially, we were working with over 2 million beneficiaries. We had a significant component which was working with pregnant lactating mothers with children under the age of 2. So we had supplementary feeding coming in, which was absolutely critical, really, to actually give that vital nutrients for the pregnant mother and the lactating mother till the age of 2. And together with all the behavioral kind of components, which really, I tell you, is the challenge. It's really getting that behavioral change in, is the magic, I'd say. If you can actually do that, then you have really done a breakthrough. So safe, hygiene, washing your hands, and that all simple things that we take for granted, but absolutely critical in the process of nutritional well-being. When we actually entered those areas, and again, the areas that we were working in were extremely remote, very difficult to get to. Just to give you an idea, one of the mounds it's a certain area in Bangladesh, which is a tectonic depression. It's waterlogged 6 to 8 months of the year. And just to get to one of these mounds, it's a man-made mound. It's like a virtual island during the rainy season. It's a 2-hour speedboat ride one way. So you can just get an impression of how remote these places are. And of course, they don't have the luxury of speedboats. They're actually working on a wooden boat with a paddle. So you can imagine how long that takes for them just to get one way from to the man and back to the mainland. So remoteness again played a major role in that. So by the end of the program, what we found was with the children that we actually worked with, the baseline was around 52 to 56%. Kids were stunted, so an extremely high prevalence of stunting. Within 3.5 to 4 years, we actually managed to bring down the stunting by 30%. And in terms of percentage points, it was 4.5 percentage points per annum, compared to a similar kind of a socioeconomic status group within Bangladesh of 0.3 percentage points. So we had a major impact, given a similar kind of a socioeconomic distribution. The worldwide average at that point was 2.2 percentage points per annum. So something obviously had worked in Shahar, though, which was quite honestly a phenomenal breakthrough. We tried to actually, again, figure out of all those different things that we did, which one of those things actually brought the most value added. And this is where the science comes in, quite honestly. And this is where we need real help, because we have limitations. We're an organization on the ground, but we need academic kind of research kind of support and actually figuring out really what brought the value for the buck, quite honestly. We made an attempt, and we did some propensity scoring to figure out what actually brought about the most significant impact. And it wasn't economic empowerment, it wasn't food extension systems, it was women empowerment. And by far it was women empowerment. And when you look at the logic of women empowerment, essentially, especially in that subcontinent, it really is the woman who's the primary caretaker of that household. So if that woman is empowered, and she's got the capacity and the knowledge, she's the one who actually determines what kind of food is brought from the market. She's the one who determines what kind of food is actually grown on the agricultural land, on the homestead, on the rooftop, all those kind of things. The chickens, goats, I mean, simple things, but absolutely transformational at a household level. So we were very pleased that we had a significant impact. Shauharda 2's now began from, of 2010, May 2010. And we're building on basically the practices of Shauharda 1, so we're very pleased. And Jada, I don't know if she's still around, but I would really encourage her to look at Shauharda as one of those evidence-based kind of models.
Yeah, it's great, and AID has used Shauharda since they were one of the major funders as a real example of a program that you threw a lot of numbers around there, but the bottom line is that program had a doubling in the impact on reducing stunting, and a lot of it was contributed to this whole women's empowerment component of it. You've all talked from different perspectives around programs that you think can have an impact, but I know from where I sit, there's always this sense of we can do but so much, and then our own organizational limitations limit what we're able to do to have an impact. So it'd be interesting from your perspective to as we're thinking about partnerships and how do we work better across different lines, how do you see what you do from your vantage point makes one set of impacts, but where are some of the gaps? How would you see your work being fortified and strengthened given different partnerships? And what has been the role of partnerships in your work? And maybe Usha, just starting out with you.
Sure. I think partnership is very important, because everyone who's probably married in this room for a long time know that you have to work at it. And that's really key in having productive, healthy partnerships, that you treat people with respect, you understand where they're coming from. And and I would say I've been very privileged to be here in Atlanta. The reason I'm still here is because of those opportunities for partnership, whether it's working with colleagues at CDC, colleagues at CARE, in programs, implementation, and there are some of us here who've moved through these. I mean, Rafa was a colleague at Emory in the academic environment, is now at CDC, comes and teaches classes. So we're able to bring what's happening in the program world to the classroom. And as I said, my sort of hat is here as the academic. My role is we are teaching the next generation of highly motivated young people who want to do a master's in public health. I also direct the program in nutritional health sciences, which is a PhD program. And we have, the person who's coming in as one of our students next year headed a fairly important portfolio at Helen Keller International, which does a lot of work in the program world. And she's basically coming to retool. So I think that dialogue or two-way street of communicating with people in different sectors is critical.
Do you have a specific example, perhaps in the work that you're doing, where there's been a key partnership that's really been able
Absolutely.
to extend? Yeah.
I can point to the one that we're working with CARE right now in India, Ray's there, and it's a partners meeting. And CARE has been working in Bihar as one of several partners of the Gates Foundation to, it's a family health initiative, and we've been working closely with Ben and his team. This is the person in charge of health at CARE in Atlanta. But really the partnership has been in the field in Bihar, where we have our team here, some of them are here today, those of us who bring in the technical expertise. So when we talk about, what are the messages, an example I can give you is the importance of focusing on exclusive breastfeeding. And, it's easy to say women need to breastfeed their children 6 months, but CARE is dealing with the on the ground. How do we get this to happen? What are the barriers? And we've sent students who are training with us to work on the ground with the CARE team. And that way there's this interchange of being in the real world, but as an academic organization, we're not isolated. The other part in that partnership, working with CARE, and as someone who's, as I said, worked in the government sector, but also worked in India, is communicating with the government. In India, the government is a big player, they're the money. And so it's having to speak the language, convince them on why you need to invest in different programs. And I'll use a very specific example of iron folic acid supplementation. This is iron supplementation during pregnancy that we've been working at, and when we initially talked, we said, oh, it's not a problem. Women don't consume it. That's the problem. And we said, can we look and see if women receive it? Is it there in the field? And so we had a doctoral student who's working on the project. It was not in the original purview, but we said, this is really important, who's gone in and worked and pulled out things that are programmatically relevant. So it's not, you know, the fancy research paper that's going to come out in the Lancet, but it's useful information that's going to make the program more effective, not just for CARE, but for the government of India and the government of Bihar. Okay, what needs to be done? Is it the training of your frontline workers? So I think that would be where we've got academics, we've got NGOs, we've got the government working together in partnership.
Yeah, I think that's great, and it really does point out, you know, looking at it from these different perspectives. You know, when you're the program implementer, you're really thinking, how do you get this program made? The researcher, the academic, thinking about what are the questions, and then how do we use that as a feedback loop that really enhances what we do. You know, Fahim, you did a lot of, in Shoharda, a lot of partnership, particularly with the government of Bangladesh.
Yep.
Be interesting to hear from your perspective how that worked. Where did that partnership come from, and what were some of the challenges there? And you know, I think it's one that's worked well, and as you said, the commitment of resources in some ways is the best example of a successful partnership. But tell us a little bit about the journey to make that successful.
Well, it wasn't an easy journey, I'll tell you that much, just to start off with. Because one of the things I think, you know, we've learned as we went through is that, you know, partnerships can be, quite honestly, they can just be there for the sake of just being there, or they can be real in intent. And I can say that when we first started off, it was just, you know, because it was in the MOU and we just had a partnership. So we had a steering committee at the national level, very disinterested, you know, people coming into that meeting and then going away. And we really actively worked on that. And what came through was that we recognized that we had to be having a presence at every tier of government. So at the local level, at the regional level, and at the national level. So eventually what happened was, you know, the ministries that we had sitting at the national level, we had mirror, committees sitting at the regional level, which is the division. We had it at the district level, and we had it at the Upajala level. Upajala is the lowest tier of government. And we ended up with about 123 of these committees. Now, it sounds a lot, but quite honestly, they were instrumental in making sure that the program was getting the kind of support and the traction needed from the surrounding support structures. Now, as we were going through the process, we recognized the government played an absolute critical role in this process, but so did, so many other partners that we absolutely had to partner with. From a development side, it was like the other practitioners on the ground. Even though Shoharda was big, we still needed active engagement of other, programs like Save the Children, ACDI VOCA. We needed help from them. So there was a cross-fertilization of ideas, learnings, and so on. We had active collaborations with research institutes, with the CGIAR group, so World Fish, there was the livestock department. All those different things actually had to come into this as well. So again, a very major role in that process. And private sector. Private sector was fundamental in our sustainability strategy. Not just Bangladesh, if you look in Africa as well, there's some enormous private sector corporations coming up. And quite honestly, we need to be actually harvesting as much as we can on these national, very big private sector organizations who do understand that this is not just a CSR thing, this is more about private enterprise. There is an actual link, to their own, business bottom lines. So all of those things played a major role as we were going through this. And what we were doing was we played a facilitation role. We understand that we're acting as a catalyst. We're there to actually build the capacities of not just our beneficiaries, but also the surrounding support structures as well. And really the trick is to make sure that there's an active and a healthy engagement between our communities and that surrounding local support structure, be it private sector or government, whatever it is. And if you're able to actually leave behind that kind of an environment, then you have a sustainable transformational change that's coming into being. I just want to finish up with one thing. One of the questions that I have for the research institutes, and this is where we need real help, is, again, bringing the ethical dimension in how we do our monitoring and evaluations. There's a challenge of RCTs. I'll openly say it, I'm not a great fan of RCTs because,
Randomized controlled trials. Yeah.
Yes, randomized controlled trials, because you actually, have, all kinds of ethical issues coming into that, because you have a control group, where you're trying to actually keep them in a laboratory kind of a situation where you're trying to actually, match and see the progress of what's happening with another group that's actually getting the interventions. The other challenge is there's some places where you have high density populations, it is quite impossible to get, those kind of control groups. So that's another challenge. So one of the challenges I throw out to the research institutes really is to come up with other kind of mechanisms that can be built into our programming that could really help us. But again, keeping the ethical dimension, in the back of your minds.
Well, I think that's a good question for Rafa. Randomized controlled trials, you've had a lot of experience with that. It is this whole issue of how we measure work in the midst of program efforts is a key one. And in nutrition, I think it's an interesting one because in lots of ways we do know more or less what works. And so the whole area of what's the right kind of experimentation, how do we get the kind of evidence we want, from your perspective, how would you answer that challenge of doing the right research, keeping that ethical balance, and really, but still getting the kind of information that gives us answers for some of the remaining challenges?
Okay, I will try to answer that, but I would like to
go back to
the
partnerships. Okay, please.
What you need is a group to compare. Not necessarily a control group, as you are thinking. That when you are thinking, I want to deprive this group of the intervention purposely, and that's unethical. If you know the solution works, you cannot do that, right? But you need to have a comparison group somehow to document the attribution of your effectiveness. And so there are creative ways, and that's called quasi-experimentation, quasi-experimental designs, that you can deal with that. And I think that with monitoring, there is not an issue of ethical whatsoever. Because by definition, if you have an intervention, you must monitor the intervention in terms of the key indicators, just to show that what you are thinking you were going to do, you are doing. So that's not an ethical issue. It's the impact evaluation, meaning the effectiveness of the intervention, where this issue of control or holding up intervention. There are 7 major designs to deal with that. And I will mention one because it's not familiar to you. You can calculate the probability of a group to be in such a condition. That's called propensity density scores. Maybe some of you have heard about that. It's a Nobel Prize for that approach in an economist. And to me, that has a lot of potential. We haven't looked at that much. But there are several ways to deal with that without not compromising the ethics.
But it's an interesting challenge, and I want you to get on the partnership, but I think this tension between, when you're on the program side and when you're on the research side, how do we first speak the same language, and then how do we actually make sure that we've got kind of shared purpose and really dealing with those tensions? So it's an interesting one, so thanks for bringing it up. But on to your thoughts about partnership.
Okay.
Yeah.
We don't implement in our International Macronutrient Prevention and Control Program impact, we don't implement. So we must and we do work in partnership because we don't do the implementation. So we have several partners. We have a cooperative agreement with UNICEF. And to be concrete how we do it, I want to give 2 examples quickly. And I pick, in the previous panel, Nutri-Butter was mentioned. That's lipid nutrition supplements, right? So, but when you put a small sachet, 10 gram sachet, now it's called LNS. We are working with the UNICEF office in DR Congo, in Lubumbashi, trying to do the first intervention, real intervention in real conditions of how you can work and use the Nutri-Butter in small quantities in the 6 to 11 months kids, if this intervention, it will really make a difference. But in order to do that, we have to work with the office, the UNICEF office in Lubumbashi, not in Kinshasa, and with the Ministry of Health in the context of an intervention Ministry of Health program. So we work always with the Ministry of Health, with an international partner that is doing an intervention, in this case UNICEF, and with us. That's one example of our partnership. We have other countries where we are working in UNICEF, in same fashion, different interventions. We work in partnership with WHO, but with WHO it's a different level. With WHO, our concentration is in global policy. So when there is a guideline to fortify wheat flour and corn flour, we collaborate with them to produce the guideline at the world level that is going to follow all the fortification all over the world. That's a high level partnership. The guidelines for micronutrient powers, home fortification, we help and work with WHO, and we have a cooperative with WHO as well. In terms with the private sector, we support and we have a partnership with the Flour Fortification Initiative. Then you have Cargill, you have Interflower, you have Bunge, in addition to the UN partners, trying to move forward fortification of wheat flour and now corn flour, and we are going into rice. Rice is not flour, the rice. So we have that type of partnership as well. We do have a partnership with Gayle, the Global Alliance for Improved Nutrition. And basically, that pretty much has been in the area of fortification. The last collaboration we had was the impact evaluation in Jordan of the flour fortification that has been then going on since 2002 in Jordan. We have a collaboration with the Micronutrient Initiative in Canada. We currently are co-chairing the Global Micronutrient Forum, and maybe later I will have opportunity to talk about that. And I wanted to mention the last two collaborations that, Emory. Emory housed the Flour Fortification Initiative. And in addition to be a part of the Flour Fortification Initiative, we have a partnership with them in terms of working with the students and the university in some of our interventions. And finally, we do have partnership with the US government in other agencies that do nutrition, with NIH and with USAID. We are starting a collaboration with USAID and the World Food Program in Uganda in a home fortification program that the government is interested. So all our partnerships always are with the government through an institution, usually a UN institution, but not necessarily, because GAIN is not UN, MI is not UN, and that's the way we work.
Mm-hmm. And it's good you brought up the role of the private sector, because I think that's clearly when we think about fortification, different types of food crop, et cetera, and that came up in the last panel, and we'll have a lot of discussion about that on the third panel in the afternoon by Wayne. But I think it is this panel, we don't have that included, but a key part, I think, of this discussion. I'm going to open it up shortly to comments and questions. We'll have about 10 or so minutes, but I just wanted the panel to react to, from your perspective, there's a lot of these initiatives going on, 1,000 Days, Sun, Feed the Future, et cetera. If you were to say, from your perspective, one thing or a couple things that could be done more, how to make them more effective, what would be your comment as you look at this range of different initiatives that are going through? How could we what would be your feedback about how we could make them even more effective towards our goal of ending food and nutrition insecurity? And Fahim, start with you. And just brief throwing out, because I do want to, and people can start lining up to the microphones for any questions or comments.
Well, I just say one comment. Basically, I think the approach that USAID's taking now, the USAID Forward, where they're actually looking at basically harnessing, national partners, get the governments on board and so on, is absolutely the correct way to actually go. So that's something that, others need to be actually, we need to be watching, learning, and seeing how we can actually engage more national governments, private sectors, and local societies.
I think these various initiatives are really exciting. They're positioning nutrition in the forefront, but often people have said nutrition kind of is like an orphan. Agriculture is big, you have health, and it kind of falls in the cracks. So my plea is, while many of these initiatives are way up there for advocacy, for getting it on the radar screen, that we need to in parallel look at what's happening on the ground level. We have a lot of success stories when they're done in a small scale, but where the gaps are in the scaling up area, and that is going to be time consuming, and it requires also support, whether it's in training, it's in sort of that the how-to part, and I hope that that implementation science, which has the NGOs, which has the academics, it has the people who are providing the money to make these, will also receive attention, because the success is in the end in that very part of actual utilization. Great. Rafa?
Yeah, I think the scaling up nutrition, the SONG movement that David spoke at the beginning, in the opening, is a key initiative at the global level. What is lacking is to couple it with investment, global investment. Mm-hmm. We heard in the previous panel that the GH is going to talk about food and nutrition security in 2 or 3 weeks. But how, and they are going to talk about commitments in money. How that is going to be coupled with some, for example. Mm-hmm. We heard about the Feed the Future initiative from the US government. How the Feed the Future is channeling or coordinating investments into the song. And so to me, that's the way to go.
Mm-hmm. Great. All right, we have a couple of speakers here. I'm also going to ask a colleague of mine, Ginger Floyd, if you wouldn't mind saying something, because you deal with a very interesting constituency that we have never really introduced, and that's the role of traditional medicine, traditional healers in some of this in your work. And so maybe if you want to say a word about that as we take some of the other, after we take some of the other comments.
Hi, I'm Tim Williams from University of Georgia. We've heard a lot about the consequences of what's not in the diet. I'm actually also very concerned about what is in the diet, but can mimic the effects of what is not in the diet. The mycotoxins can do this, and we know that mycotoxins are pervasive across the developing world. Everyone is pretty much exposed, and I urge the nutrition people to actually pay attention to this, which can undermine the good work that they're doing. It is a really important problem. Thank you.
Thank you. I don't know if anybody has any specific comment on that, but.
Hi, thank you. I'm Veronica Luco. I'm a doctoral student at Georgia State University, and I've been studying gender quotas in the developing world. And I had a question. As you see, over 100 countries in the world have gender quotas. In Africa alone, there's 35 countries. 9 of them have over 30% women in the legislature. So my question is, how often or how much of a plan do you have working with these women in these countries, in the legislatures? I know a lot of caucuses are being developed. How effective are you with working with the women? Because the research is showing that they do have more of a concern for these policies that you're trying to push through. They are, a lot of times, they push for these policies. So that's my question. How much do you work with the caucuses in the developing countries?
Great. I don't know if you may want to say a little bit about some of the work in Bangladesh.
Yeah,
and other places.
I can just very quickly just say one thing. The gender dynamics absolutely plays a critical role in all of these things. But just again, if I just talk about Bangladesh, the Prime Minister is a woman, the opposition party's leader is also a woman. Doesn't mean anything, quite honestly. It's really a case of actually trying to actually get those kind of gender-sensitive kind of environment. It's a major role. And we were very fortunate, just recently, Prime Minister Sheikh Hasina, she's now taken a personal stand in women empowerment and gender empowerment. And that's made a lot of traction. But again, that's at a policy level. But trying to get these kind of things now, again, all mainstream throughout the system is very, very complex. There's quotas where basically there are a certain number of women that actually have to be fulfilling, so that there is a cabinet at various levels. But the role that we play, again, is really trying to actually sensitize, and this is where the men engagement is so important, to make sure that those women are not just there as just sitting on a table, that they're truly empowered to actually have a voice and make a decision.
What you really meant to say is not that it doesn't mean anything, is that that's just not enough.
I stand corrected, yeah, absolutely. That's what I meant.
All right, we'll go to that, Mike.
Amy Webb-Gerard from Emory University. Also worked with Usha on the India project with CARE and worked with her on the project on maternal nutrition out of Nigeria. I just want to speak briefly about some of my own experiences working on nutrition-sensitive agriculture projects in Kenya and community-based participatory strategies for behavior change around maternal and child nutrition in Sierra Leone and Kenya. Because it's a few of those key learning lessons that you were asking about. And it builds on the issue of social and behavior change as being such a key fundamental point when we're trying to make improvements in hunger, food security, and nutrition, especially for women and children. Some of the lessons that we have learned is the absolute need for participatory engagement with communities and going beyond just targeting mothers with messages, but including those key change agents, those key keepers of traditions around maternal and child nutrition, which by and large are mother-in-laws and elder women in the community, but also in other cultures, the husbands who make primary decisions in terms of how resources will be allocated in the household. These people must be included in our design, in our prioritizations, and in the way that we implement strategies, because when they're left out, the women who we're trying to target will come up with immense struggle in the household if they're trying to effect changes that are not supported by the other members of their household. So that was just one thing I wanted to comment on. The other is building on the local traditions that are valuable and important. And this comes very much from the positive deviance literature, where within communities that are extremely poor and marginalized, you will find examples of positive practices that can then be used as peer support and peer networking, so that people can learn from their own as opposed to us coming in from the outside to impart some form of knowledge. There is a vast amount of local wisdom within communities that can be tapped on. And those are just two of the things I wanted to build on with those comments from above. Thank you.
Thanks.
What a nice segue. What a nice segue. I'm Ginger Floyd at the Morehouse School of Medicine. And WHO basically tells us continually that 80 to 85% of sub-Saharan Africa gets its health care and health education from traditional healers. Whether you believe them or not, that's where they go. And so in our work at Morehouse School of Medicine, we've partnered with a network of traditional medicine organizations across Africa, which is called ProMetra, trying to understand what we call the right message and the right messenger. If indeed they are the right messenger, they have 85% of the population, or can we help them make sure they have the right message? And in that work, we are doing lots of things. We are looking at their HIV plant medicines to see whether they're effective and safe. They received the Gates Foundation grant to look at the issue of immunization advocacy up in northern Nigeria. Why aren't folks taking these vaccines? Maybe we should talk to the folks who actually know why. And one of the things that probably Helene is pointing to is ProMetra and its team, its self-sustaining arm, its profit arm, actually has a Clinton Global Initiative nutrition commitment that looks at micronutrient malnutrition in terms of a population in Senegal, where they have given this, it's this micronutrient vitamin fortified powder in relationship and partnership with Procter & Gamble and Gain and the World Bank Institute. So it's an ongoing commitment that they're in the process. I'll be happy to talk to anybody about it. But the truth of the matter is what we've learned at the Morehouse School of Medicine, if you want things done, if you want behavior to change, if you want people to become healthy and make decisions, you should talk to those change agents who are those indigenous leaders who actually have this great capacity, levels of respect, and major influence. We have seen them shut down health programs that they were not involved in. Anyway, thanks.
Yeah, no, and I thanks so much for that, because I really do think as we think about this whole issue of behavior change, I think some of it is that we missed the boat by talking to the wrong people, and how do we really have this broader dialogue with the representatives of communities broadly if we really know that some of it is not just finding the right answers, but then how do we actually implement that by this broad behavior change. Last comment.
Hi, my question is regard to policy development and implementation. Dr. Gayle, I understand that you're very involved into policies, but when you decide, this goes to everyone that policymaker, when you identify a country and a target problem, do you have a local advisor, or you just, it's pretty much kind of going along with a question, do you have a local advisor, or you just identify the problem and implement it? Because most of the time, you might identify as malnutrition as the problem, but there will be other problems related to the malnutrition. If you give them food and they don't have clean water, they eat it and everything goes away. So it really doesn't make much of, it's not sustainable.
Yeah, and just generally, I would say, in the work that we do, and I think most of our partners, it is working in harmony with communities. So looking at what are their needs, what are their highest priorities, and then helping to develop programs that address the issues that communities themselves feel are the highest priorities. So it's very much, I think, the way that we see doing development. And I think it's the way a lot of our partners do. That said, we know that there is this delicate balance, and you spoke to it, Usha, about here we have these global issues, and we set these big global priorities, and I don't think any of us feel like we're doing enough to make sure that what happens at the country level links with these global initiatives and global priorities. So it's a key challenge for all of us to do better, to think about how do we make sure that what people's greatest needs are link up with our overall global look at these things and continue to make those kinds of iterations. I think we are out of time, but thank you all for being such a wonderful participatory audience, and thank this panel for what I think was a really, really stimulating set of discussions. Thank you.
That was terrific. Well, thank you very much. That was terrific. Our schedule is such that we want to invite you to take a 15-minute break. You can leave your materials on the chair. We have a wonderful lunch that's been prepared for you, and then we'll hear from the company that knows among the most in the world about global food security right after you come back. 15-minute break, really on time, because we'll tune back in just a few minutes. Thank you.